Hello and welcome to
That was a very exuberant beginning to a podcast.
It's the music. It just gears you up.
It gets you ready for it,
Really
doesn't
does.
it? Yeah.
We start that again.
No, that's it.
Really?
That's the beginning of the podcast.
Okay, well, hello and welcome to another exciting world of podcasts. And tonight, or today, or whenever you're listening to this podcast, we're going to be talking about the febrile child. So, what are we talking about? Is this an important condition? Common causes? And then we're going to talk about a way of assessing somebody with a febrile illness and a systematic approach to the assessment. And then finally, based on your assessment, the ways of managing somebody. So is this important? Is it, Ed? Is it really important?
It is very, very important. Febrile child, or the clinical scenario of a febrile child is exceedingly common. It's something done every day by general practitioners and also in the hospital setting by paediatricians. It's also a bit of a hot topic. The Confidential Inquiry into Maternal and Child Health, published in 2008, highlighted some really important learning points about how we as medical practitioners should be approaching the assessment and management of the febrile child. And as such, I'd say it's pretty much a core competence for anyone who's going to qualify as a doctor to be able to accurately and completely assess a febrile child. And lastly, as I've already mentioned, it's a bit of a hot topic. So lots of guidelines recently being produced, NICE guidelines, drugs and therapeutics bulletins, and some important studies, which I'm going to mention also in this podcast.
Literally a hot topic.
Literally a hot topic, yes. Thank you.
It's just, I had to mention the comedy link there.
So, what is a temperature? Well, unsurprisingly, a temperature is an elevation of body temperature above the normal daily variation. And in most people's minds, this is associated with infection. Specifically in this podcast, when we talk about the febrile child, I want to focus mainly on the recent guidelines that have been proposed for the age group of under 5s. However, the principles that we're going to outline in this podcast, I think, can pretty much be applied throughout paediatrics.
Indeed.
What is the temperature? Well, greater than 37.5, I think, is a reasonable value to have in your head. Bear in mind that there is some debate about this, and that the absolute level that you would consider a temperature to be present depends on how you're measuring the temperature. For example, rectal temperatures are actually even higher than this. And you tend to get some diurnal variation with temperature as well, and it's thought that we alter our temperature by plus or minus 0.5 of a degree throughout the day, with the lowest point being in the morning and the highest in the sort of early evening. So that's just worth bearing in mind. The next issue is, where do we measure this temperature? And I've already said that this is important because if you measure a rectal temperature, then actually a normal rectal temperature is about 38.5. So if you measured all temperatures rectally, you label every child as being febrile. And the most recent guidelines say that any kid over 4 weeks, you use one of the standard infrared tympanic thermometers. If the kid's less than 4 weeks, then you use an electric thermometer in the axilla. We don't anymore use oral temperature. So gone are the mercury thermometers that would sit under the tongue for a couple of minutes. Mm-hmm. And also we don't do rectal temperatures anymore either. What we do, or what we use, are these. These are all instruments made by Welsh Allen, who supply a lot of the UK diagnostic equipment on wards. And one on the right is the infrared one that I'm sure you've all seen before. And the one on the left is the electronic temperature probe that can go in the axilla for those kids under 4 weeks old.
So next up are the common causes. So Ed, do you want to just tell us a bit more about the ways of just sort of quantifying or thinking about the causes?
Yeah, so I think the first thing to say is that most of the time, most of the children that you see with temperatures are going to have sort of upper respiratory tract type infections, okay? And these tend not to be very serious. However, occasionally you will get things that are more serious, Okay, and now the difficulty is that you can't just say, oh well, it's probably going to be an upper respiratory tract infection, so we'll just treat them conservatively. You have to look every single time for the rare, complicated things that need definitive management there and then. So what are the causes? Well, I've tried to outline some of them here, but the key ones and the sort of rare but very important ones I've highlighted in bold. And these obviously are meningitis, which you should be aware of, the tumbler test, etc., pneumonia, urinary tract infection, and septic arthritis. Those are the ones that really you want to get a handle on if the febrile child comes in, because they will need definitive treatment there and then, or at very least definitive referral to someone else who can provide treatment. Other common things are things like otitis media, pharyngitis, tonsillitis, bronchitis, gastroenteritis, any of the exanthems. We're seeing these less and less with the increased uptake of MMR, but you still will see exanthems. And then, of course, you've got the really, really rare stuff, things like the fever that persists in something like Kawasaki's disease. But what I want you to take away really from this little section is that common things, yes, they are common, and the febrile child is common in itself, but you always need to look for the rare but ultimately treatable things and things that need your attention.
And would you say that those are the things that you want to rule out first?
Yes, absolutely. I mean, I think, as we're going to go on to show, all of these things are things that you should be asking about specifically in your history, and you should be looking for specifically in your examination.
So how would you mentioned about the questions and the examination. Have you come up with a way of assessing a patient in a systematic way?
Well, I haven't come up with a way, but the National Institute of Clinical Excellence, which is a advisory body in the UK, has. And this is how they recommend. So basically, your approach should be always life-threatening features. I mean, this comes from adult medicine as well. You always assess the patient from the perspective of A, B, C, D, airway, breathing, circulation, disability, etc. Now, this doesn't have to be a detailed assessment. Often, if the kid's walking in and holding the hand of their mum, then obviously they've got patent airway, breathing, circulation, etc. But that's just to say, in extremis, those things have to happen first. So the approach that NICE has introduced after you've done that is this, what we call the traffic light system. So you obviously, traffic light, green, amber and red. Okay, and this diagram really just illustrates those principles in more detail. And let's start at the extremes. Okay, so in the circumstances of the child not having symptoms and signs of very serious illness or specific diseases, which I've spoken about before, then one might class the child as a green light. Okay, so we're not worried about this child. They can go home with appropriate care advice, and if the mother thinks appropriate, or the father indeed, they can be seen again. On the other extreme, you've got red for stop. Worry about this child. This child has symptoms and signs suggestive of serious illness, and they need to be assessed as an emergency by a paediatric specialist in a hospital setting. And then in between that, you've got a fairly sort of, I wouldn't say common, but something that you certainly see more than the red class, where there are features of both. And in that situation, you need to, first of all, obviously make a judgment about whether the child needs to be assessed by a paediatric specialist. But certainly in the primary care setting, it's the kind of situation where time becomes an absolutely crucial diagnostic tool, and educating the parents about the development of worrying signs and things can be very, very useful. Okay, so how do we get to these different categories? Well, NICE recommends looking at these things. So looking at colour, activity, respiratory features, hydration, and what they helpfully put at the bottom is other. Okay, and these are all actually things that are quite sort of, they make sense. For example, colour, if the child walks in and they're pale, mottled blue, then that obviously is red. If they walk in and they have very good colour with rosy cheeks, etc., good colour to their lips and tongue, then that's clearly green. The same with activity. If the child walks in, responds normally to social cues, is content, in the company of their mother, has a strong normal cry, then that is green. On the other hand, if they come in and are not responding at all, and interestingly, or if they just appear unwell to a healthcare professional, now this is very important. We can have we can measure pulse, we can measure respiratory rate, we can measure temperature. All of these things are not as accurate as an experienced healthcare professional looking at a child and making an assessment of, is that child well or are they unwell?
I think the parent or the guardian as well, Ed, has a pretty good insight into that. And they'll probably just tell you straight away that
they're totally off.
Exactly, yeah.
And then respiratory. Respiratory is really, really important in kids. And notice also how, the first box to be filled here is in the amber or red. When kids start displaying respiratory compensation, as shown by things like nasal flaring, tachypnea, reduced oxygen saturations, severe signs of using excess muscles on the chest, then something really is wrong, and that would probably, for me anyway, means this child would need to be assessed. So it puts them nicely in the amber or red category. Hydration is another very important thing to look for as well, and we'll talk about that a little bit later. And then at the bottom we've got other. Now other actually just includes certain things that point towards some of those bolded up causes that I spoke about earlier. So things such as swelling of a limb or joint that might point to a septic arthritis.
Right.
A non-blanching rash that might point to meningitis.
Yeah. Right. Yep.
Focal seizures, once again meningitis, bile-stained vomiting, things like this. These are worrying signs. Okay, but we'll get to that a little more in a moment. So, how does this actually work in practice? So, in practice, we have our emergency assessment. Yes, of course, A, B, C, D. But then, as always, you do a history and an examination. Now, when taking a history, I think the key thing is to try and establish two things. Try and establish where the infection is. What is the source of the infection? And you do this by focusing on asking about focal symptoms, asking about specific symptoms that point to a source of infection. And then secondarily, you want to establish what is the effect of that infection on the child.
And Ed, for those who haven't or are just starting paediatrics, who are you going to be taking the history from?
Well, obviously, especially the age group under 5, they're not going to be able to give you a very detailed history. Sometimes I wonder, a lot of adults aren't able to give a decent history either. But you're going to be mainly, of course, focusing on the carer of the child, usually the parents, of course, whoever they come to the surgery or the hospital with. Mm-hmm. So these are just some ideas of how one might assess severity. I mean, the things about assessing the cause, those are things you'll have to know from your medical general knowledge. If a kid's got diarrhea, you need to consider gastroenteritis. If they've got a sniffly nose and a sore throat, you need to consider upper respiratory tract type conditions. But this is the thing that's really important, and this is the thing that you have to ask about in every single kid, even if they have a simple upper respiratory tract infection, because you never know if the child may also have some chronic disease going on in the background or anything like that, and a simple infection may have a severe effect on their function and might be quite severe. So these are the kind of questions that you'll be asking. How is the child compared to normal? Are they eating and drinking? Now, you'll hear the same thing over and over again. Parents will always say, they're not really, they're off their food, but they're drinking. And that sort of, for me, is a green light. You expect a child to be off their food when they're unwell. Are they playing as normal? If a child's playing, most of the time it means they're probably okay. Are they sleeping okay? This one's a bit woolly. Sometimes, often children who are unwell don't sleep particularly well, and particularly kids with upper respiratory tract infections, they tend to get their cough a lot at night. Are they got wet nappies? That's simply a way of measuring, sort of a crude measurement of urine output, if you like, and thus dehydration. Are they opening their bowels? Less important than the wet nappies, but is important to ask about. And then finally, are they consolable? This one is really quite important, because if they are inconsolable, that might put them in one of those amber or indeed red light categories. Now, moving on to your examination. For examination, you need to have a system. Okay, and I would say that the absolute key is to look at the child. It does the child seem well or unwell? As they come into the room, do they look well or are they unwell? Now, obviously, I'm sure many of you won't have had a lot of experience with children, and this is an element of the examination that will grow with the more children that you see in a medical context. But this is a really, really crucial thing to try and develop. The next thing is really advice that's been given by NICE quite recently, and this is that all children should have the following basic indices recorded in the notes, and all of these things should be assessed. And obviously, depending on the age of the child, there are lots of different normal ranges. I'm not going to go through these here because you can look them up anywhere. But of course, temperature, as we've already said, is important. Heart rate, respiratory rate, and you also need to mention here, are there any signs of respiratory distress? So are they using accessory muscles? Is there nasal flaring? And then capillary refill time, and this is really is as a measure of dehydration. And then for the actual examination, I like to certainly do just a top to toe. That's how I think about it. So I start at the head. So for example, if they're a young child, I might start by feeling the fontanelles. I then move down, I look in the ears, feel for lymph nodes. For the throat, I tend to leave till the end of my examination because often, certainly in younger children, it can be difficult to get them to open their mouths. Often you have to coerce the child together with the child's mother, and sometimes, unfortunately, you can make them gag and indeed throw up. So I like to leave that to the end. Listen to their chest, look for all of those accessory muscles being used, nasal flaring, feel of their tummy, and this is really important. Undress the child. Look, do a complete survey for any rashes, because a meningococcal rash is not going to be like the ones you see if you go on Google Images. It may just be a small area, on the foot or on the back, and so you really, really must look for it.
So Ed, you've assessed the patient through a history and a detailed examination. So I guess now really you're just using what the NICE guidelines and tallying all that information together to work out which box to put them in.
Exactly, and that's exactly what it is. It is a sort of, rather than sort of saying, okay, this child has this feature, looking at all the boxes of the guidelines and saying, oh, that puts them therefore in an amber category, a green category, or a red category. What I think it's more useful to do is, when you're going through, sort of adapt your opinion. So, a child might come in and they don't look very well, so you start at amber. But then when you start hearing the history, when you start hearing that they're sleeping okay, that they've got wet nappies, that they're feeding well, etc., they slowly move to a green, and then, goodness me, you examine them and you find a rash, and of course they go straight to a red. This is an adaptive process. It's not just something that you sort of just come to. So I think it's important to bear that in mind. But this is the essence of this system, is that the primary management option depends upon which group you put them in. Okay, so if they're in a green, they can go home with appropriate care advice, etc. If they're in a red, they need to go to see a paediatric specialist. Do consider if any definitive management is needed. So for example, things that you might do, say in a primary care setting, if a child came in with a urinary tract infection, that might not necessarily mean that they needed to go straight to hospital, but it certainly would mean that they would need antibiotics. So is any definitive antibiotic therapy or other therapy indeed needed? As mentioned before, however, most of the time the febrile child will have a fairly trivial upper respiratory tract type infection, otitis media, pharyngitis, tonsillitis, etc. If you want to know about the detailed management or definitive management of those, you can look it up, but certainly there's a pattern that we're moving away from using antibiotics. It used to be the case 10 years ago that otitis media would be antibiotics, tonsillitis antibiotics. We're moving away from that now as it's recognised more and more that actually antibiotics make very little difference to the course of these conditions. What is important is having a really good grasp on what one might call symptomatic management of children with trivial infections, trivial upper respiratory tract infections. And this is where this crucial pitch study comes in, published in the BMJ in 2008. And there are a couple of key points here. The first is encourage fluids, and for mums who are breastfeeding, this includes breast milk. The next thing is to it's to try and control the fever. Or actually, it's not to try and control the fever. What we now know, and what we've been recommended to say to parents, is that fever is a normal response to infection. And certainly we know from animal studies that actually having a fever reduces the length of an infection. But the important thing is that children, and indeed adults, when they have a temperature, they get distressed. It's uncomfortable to have a temperature. And in the situation where a child has a fever and is distressed, then it is appropriate to give, to employ measures and to give sometimes medications that can reduce the temperature. It used to be the case that tepid sponging was recommended. This no longer is the case. Instead, it's recommended that the child wears loose clothing and is given plenty of cool fluids, which of course also helps with the dehydration. In terms of drugs, this was a big focus of the pitch study, but the two drugs that have traditionally been used are paracetamol and ibuprofen, and often sometimes in combination. The study seems to come down on the side of ibuprofen as an antipyretic, as this works faster and for a longer period of time. There is, however, a caveat to this. Children in whom you're worried about their hydration status, ibuprofen should be avoided because it can precipitate renal toxicity. Paracetamol, on the other hand, although not as fast or as long acting, is pretty much always safe. And then the last thing that's really important is education. So educating the parents, educating them about fever. A lot of parents are very, very scared that a child with a fever will have a convulsion. They may have had a child before that had a convulsion. So educating the parents about fever is important. Educating them about dehydration, the signs of dehydration, educating them about the tumbler test for rashes. This is also important. And it can often be useful just to provide a simple information leaflet to these parents. And of course, finally, give the power back to the parents to bring the child back if they have any worries. That's really, really important.
Oh, thank you, Ed. So just to summarise, I think we've told you all you need to know about the febrile child, and making sure that you recognise those common causes that we've given you a lovely list of, and to remember those slightly rarer but important conditions that we put in bold, and then coming up using the NICE algorithm, a way of assessing the patient through history and examination, and depending on your findings, working out if you're going to put them in a green, amber or red box, and therefore depending on that, what is the definitive management. And as Ed said, even if you're not too sure, then you can always bring the patient back in and with good education and advice, alert the family so that if they see any changes, that they can always bring the child back into the GP or into the hospital.
Great.
Well, thank you.
That's done. Bit of a ropey start, but we got there in the end.
No, I think it was fine. All the way.
All the way. Okay. We'll see you soon.
Take care. Bye.